Good day, I am Dr. Teke Apalata, a clinical microbiologist, and today we are going to discuss hepatitis C viral infections. So let me share this screen. So I say that we will discuss hepatitis C infection. And let's start with the geographical distribution of hepatitis C. Globally, it is estimated that about 71 million people are living with chronic hepatitis C infection. Okay, and according to the World Health Organization, in 2015, they found that about 1.75 million new cases of hepatitis C were detected worldwide. So this means that we have almost 24 new cases of hepatitis C out of every 100,000 people that are diagnosed. So a significant number of those who are chronically infected will then develop cirrhosis and liver cancer. And in 2016, the WHO also confirmed that we had almost 399,000 people who died from hepatitis C, and most of them died because they developed cirrhosis or they developed liver of the cancer. So this is a very, very big problem. And the condition is found worldwide, but the highest prevalence is found in the WHO Eastern Mediterranean region and in the European region, where you find the highest prevalence. The Eastern Mediterranean region has a prevalence of 2.3%, and the European region is 1.5%. Now, the rest of the world, the prevalence in the rest of the world is ranging between 0.5 to 1%, as a prevalence of hepatitis C infection. And this is a very big number. So depending on the country, hepatitis C infection can be concentrated in certain population. For example, 23% of new cases of hepatitis C infection was found among the injecting drug abusers, and they also represented 33% of the mortality. Now, in other areas where infection prevention and control practices are historically insufficient, hepatitis C is widely found distributed within the general population. Okay. And the other challenge is that hepatitis C has multiple strands, or we call genotypes. It has multiple genotypes, and their distribution also varies by region. So we will see the impact of those quasi-species diversity of the virus across the globe, how it impacts especially on the treatment and the response to the treatment. This is the biology of the virus. It is a RNA virus, and it has a number of proteins. It has 4 structural proteins. We have the C, that is what we call co-protein, and it's the much more conserved region of the virus. Then we have 2 envelopes, glycoproteins, the E1 and the E2, and especially E2, it's really a variable region. That's where most of the mutations in this virus takes place. So then we have the NS1, that is the P7. It's actually the P7. It's the 4th structural proteins that you found. And we have 6 non-structural proteins. So we will look at all these proteins with much more details and the role that they play. Now let's look at the structural proteins. Now, and the first one is the coprotein. I say that the coprotein is highly conserved basic proteins, that is found in the viral nucleocapsid, and it consists of about 191 amino acids. And it interacts with numerous other cellular proteins, and it affects host cell functions. So it interferes with the gene transcription, it interferes with the lipid metabolism, apoptosis, and other various signaling pathways. And the coprotein is directly or indirectly involved in the hepatocarcinogenesis. It means that in the development of the cancer of the liver. And it also plays a major role in steatosis hepatitis. Okay. Then we have two enveloped glycoproteins that are E1 and E2. The E1 serves as the fusogenic subunit, and the E2 plays a role of the receptor binding subunit of the hepatitis C envelope. Okay. Then, as I said initially, E2 contains two hypervariable regions called HVR1 and HVR2. So those are two hypervariable regions. So most of the mutations of this virus happens here. And the reason we don't have a vaccine against hepatitis C, it's because of these hypervariable regions, because of a lot of mutations that make the virus to escape, the immune response. Even if you develop a vaccine with against a specific, using specific antigens, you build the antibodies against those specific antigens, but because of high mutation of the virus, you will always have a new mutant that will be able to escape the response. Numerous studies have highlighted the genetic heterogeneity also of the HVR1, which may enable the virus to evade the immune system and then make the infection progresses toward chronicity. So, but it has been also found in animal models that chronic infection could still happen anyway, even when there is no heterogeneity of HVR1. So this is still a very complex virus to try to understand. Then the last structural protein is the P7 protein. The P7 protein is a 63 amino acid polypeptide, and it is a membrane spanning protein located inside the endoplasmic reticulum, and those proteins form what we call ion channels that play an essential role in the virus, in the infection caused by this virus. So the hepatitis C P7 has characteristics that are almost similar to those of a group of proteins that we call viroporins. And they play an essential role, into assembly and the release of infectious virions in a genotype-specific manner. So we can see that they play a major role in viral replication. So then let's look at the 6 non-structural proteins. The first one is non-structural protein 2 or NS2. So NS2 is a transmembrane protein, and it is essential for completing the viral replication cycle. So it plays a major role during the viral final stage of the viral replication cycle. Then you have the NS3. NS3 has a multifunctional activity. It might play a role as a serine protease. It has a serine protease activities. It has a C-terminal NATPase or helicase activities, and as a serine protease, it turns out to influence the host the innate cellular host defense, by inhibiting a number of mechanisms inside the host, like it inhibits the activity of the toll-like receptor 3 signaling pathway, for example. And as the NTPase or helicase domain of NS3, its domain resides in the C-terminal 465 residues of the NS3 proteins. So that activity is found there, and it's very critical. Then you have the NS4A. NS4A plays a major role in phosphorylation, and NS4B plays a major role in terms of recruitment of other viral proteins. And the NS4B also interact with NS4A, and therefore indirectly with NS3 and NS5A. So it has a multifunctional activities. Then the NS5A is a hydrophilic phosphoprotein, which plays an important role in viral replication, modulation of the cell signaling pathways, and responses to the interferon. Then the last non-structural protein is the NS5B, that is a tail-anchored protein of almost 65 kilodalton in size, and it acts as an RNA-dependent RNA polymerase and plays an important role in the synthesis of the new RNA genome that will be formed. So you will see that hepatitis C is quite well equipped with both structural and non-structural proteins. Now, how does hepatitis C manage to escape, the host immune response? Or what are the mechanisms of viral persistence and evasion strategy? Because it's very difficult to have a successful vaccine or even immunoglobulin against hepatitis C. Well, little is actually known about why some people will have cellular immune responses that are broad and vigorous, and many other people will develop very ineffective response. But it seems likely that quasi-species diversity that we see, those different strands of the virus, is actually the result of, rather than the primary cause of viral persistence. So those quasi-species diversity is actually the consequences of viral persistence, not the cause of persistence, because initially it was thought that the quasi-species diversity was the cause of viral persistence, but it is actually the result of viral persistence. Then the current hepatitis C sequence variation and immune escape from both T and B cells are the ones that are thought to play a major role in viral persistance, how it is able to evade both immune response T and from T and B cells. Now, let's look at this with more details, okay? So, hepatitis C interferes with innate and adaptive immune responses in several ways. The first one is that this virus is able to impair the interferon signaling pathway, and as a result, the non-structural 3 and 4A proteins of the virus will block the RIG1 activation and also translation of the IRF3. So by then interfering with the interferon response, interferon signaling response. That one. The second thing is that the co-protein, that is a structural protein C of the virus, is able also to interfere with the JAK-STAT pathway by activating the JAK-STAT signaling inhibitor called the SOCS3. As a result, it will increase the degradation of STAT1 and inhibits activation and translocation of this STAT1. So it will then affect the immune response. The E2 glycoprotein of the virus also inhibits what we call the protein kinase receptor activities, and it also inhibits the natural killer cell function of the host. You know, it then interferes with both innate and adaptive response. The NS5A also plays a major role, you know, in affecting the interferon response. The NS5A also induces interleukin 8, that is a chemokine that we know that inhibits the antiviral action of interferon. So it also plays a major role in interfering with both innate and adaptive immune response. And furthermore, the E2 cross-link the HCV receptor that we call CD8-1, thereby inhibiting the cytotoxicity and interferon production by natural killer cells. So we can see that this virus is well equipped to be able, using both non-structural and structural proteins, you know, to try to escape the host immune response. So it will impair both innate and adaptive immune response. The virus is also able to escape from adaptive immune response through several different mechanisms, such as mutational escape and functional energy of the virus-specific T cells. The cellular immune responses, such as CD4 or CD8 cytotoxic T lymphocyte, cause long-lasting inflammatory reactions against the virus. And it is now identified that because of that, it plays a major role in the development of liver cirrhosis and hepatocellular carcinoma, because you have that long-lasting chronic immune response, you know, against the virus. So that leads to the development of liver cirrhosis and the development of carcinoma. There is also a very weak T cell responses that are weak T cell responses resulted poor control viremia and persistence. That will lead to the poor control viremia and the persistence of the virus. We also have mutational escape of the hepatitis C virus from adaptive immune responses. That has one of the major viral evasion strategies. So we found that there are mutational changes in the viral particles that are due to lack of proofreading activities of the RNA-dependent RNA polymerase and high replication rate, you know, of the virion per day. So that leads to high replication rates of the virion. Then sequence changes in the hypervariable region of the E2 envelope. Remember, we spoke about this glycoprotein E2 that has two major hypervariable regions, you know, that then leads to the escape of the virus from the B cell epitope. So we will then have a lot of hepatitis C mutations that affect the virus-specific CD8 T response by decreasing the binding affinity between the epitope and the MC molecule, you know, by decreasing the T cell receptor, you know, recognition, and then impairing proteasomal processing of the hepatitis C virus antigens. So we can actually see that this virus is well equipped to try to escape the immune response and to use the persistent chronic immune response for the development of complications that we see, like liver cancer and cirrhosis development. So now, what is the natural history of hepatitis C virus? Now, among people who are exposed who actually develop acute hepatitis C infection, 15% of cases will resolve naturally without anything. But then 85% of cases will progress toward chronic infection. And among those who will develop chronic hepatitis C infection, about 80% will, have stable conditions with a stable chronic liver condition that will be stable, but 20% will develop liver cirrhosis. And then those with liver cirrhosis, 25, 1 out of 4 will develop hepatocellular carcinoma. They will require liver transplant, and most will die. And this actually is precipitated if there is a co-infection with HIV, or if you have a history, the patient has a history of excessive alcohol intake. That also make the cirrhosis to progress very fast toward the development of the hepatocellular carcinoma. So how is the transmission of the virus done? It is a bloodborne virus, and it is mainly commonly transmitted through injecting drug use, through the sharing of injection equipment. It's also because of reuse or inadequate sterilization of certain medical equipment. So mainly the syringes and needles in healthcare settings. So that's where the transmission also takes place. Transfusion of unscreened blood and blood products, so blood to be transfused need to be checked for both hepatitis B and also hepatitis C. And sexual practices that lead to exposure to blood, for example, among men who have sex with men, particularly those with HIV infection or those taking pre-exposure prophylaxis against HIV infection. Hepatitis C, as I say, can also be transmitted sexually, and it can be passed from an infected mother to her baby. However, these modes of transmission are less common as compared to the needle stick and sharing of sharp equipment. Hepatitis C is not spread really through breast milk, food, water, or casual contact, such as hugging, kissing, sharing food or drinks, with an infected person, as compared to hepatitis B. We don't really see those cases transmitted, being able to transmit hepatitis C. But what are the risk factors that are associated with the viral transmission? We have transfusion or transplant from infected donor, injecting drug use, hemodialysis, accidental injuries with a needle or sharp, sexual or household exposure to anti-hepatitis C positive contact, multiple sex partners, and birth, to being born from a hepatitis C infected mother is also a risk factor. So the average incubation period ranges from 2 to 26 weeks, but no, the range is from 2 to 26 weeks, but the average incubation period is 6 to 7 weeks. It's still a very long incubation period. And 20 to 30% of infected people will develop jaundice. 70 to 80% might have no clinical symptoms. And that's why the vast majority, 70%, will then develop chronic hepatitis, because they might not even be aware that they had acute hepatitis infection. Then 85 to 100% develop what we call persistent infection. There is no protective antibody response that is identified. So if you do serology, we will see in the diagnosis, you will find that the antibody anti-hepatitis C are there, but they are not protective. They are not protective, okay? So those who are acutely symptomatic, they might also, besides jaundice, exhibit signs like fever, fatigue, decreased appetite, nausea, vomiting, abdominal pain, dark urine, gray color feces, joint pain and jaundice. In 20 to 30% of cases will develop jaundice. So let's look at chronic hepatitis C infection. The spectrum of chronic hepatitis C infection is essentially the same as chronic hepatitis B. If you missed our lecture on chronic hepatitis B, please just check our lecture on chronic hepatitis B. All the manifestation of chronic hepatitis B infection may be seen, but at a very low frequency, like chronic persistent hepatitis, chronic active hepatitis, cirrhosis, hepatocellular carcinoma. So hepatitis B is actually much more devastating. But then the good thing with hepatitis B is that we have a successful vaccine, we have immunoglobulin to prevent that. But hepatitis C, we have nothing because of high rate of mutations that we have discussed. So the laboratory diagnosis, you can start by doing, looking at serology. You do hepatitis C antibodies. It's just generally used to diagnose hepatitis C infection. So it just tells you that the person is exposed with the virus. It does not tell you that he is now protective if you found the antibody. It just gives you an idea, then you can go and do molecular tests, to try to confirm if there is active infection or, what genotype is there, and so that it can allow you to better manage your patient. So this is not useful in the acute phase, as it takes at least 4 weeks after following exposure before that antibodies, appears. Then you can do the PCR, to look for hepatitis C RNA. There are various techniques that are available. There are PCR that can be done. There is what we call branched DNA that can also be done. It may be used to diagnose hepatitis C infection during the acute phase, because remember, during the acute phase, serology might not be useful. However, the main use of PCR is mainly to monitor the response to antiviral treatment, to assess the viral load, response. You can also do the hepatitis C antigen. Hepatitis C antigen can be done using enzyme immunoassay technique, that are available. It is used in the same capacity as RNA test, but it's much more easier to carry out, in a less equipped lab. So because new hepatitis C infections are usually asymptomatic, few people are diagnosed when the infection is recent, So then most of those people will then go and develop chronic infection. So the diagnosis is done in 2 steps. One is actually to look at antibodies. Then after that, those who test positive with the presence of antibodies, you can then do a nucleic acid test for hepatitis C is needed to confirm chronic infection, because about 30% of people infected will clear their infection. So after a person has been diagnosed with chronic hepatitis C infection, he or she will have an assessment of the degree of the liver damage. So we can then do a biopsy to try to see if there is a present fibrosis or cirrhosis. Then the degree of the liver damage is used to guide treatment decision and manage our patient. So this is the serology. You will see that the antibodies start increasing, and it can become visible only after 4 weeks following exposure. Then you have the anti-C, but the viral load is still very high. So when you do PCR, you see that it's still there. The ALT is variables, it's variables. So the antibodies are very high, but they are not protective because the symptoms will still be there. The viral load will still be very high, despite the presence of antibody anti-C. So the treatment New infections are usually asymptomatic. That's what we say. The treatment infection become mainly when it becomes chronic, and the goal is of hepatitis C treatment is how to try to cure the virus. And we have the new updated 2018 guidelines that recommend therapy with pan-genotypic direct-acting antivirals that we call the DAA. You know, they can cure most persons with hepatitis C infection, and treatment duration is also short, between 12 to 24 weeks. You know, depending on the absence or presence of cirrhosis, the duration of treatment can be increased. So the WHO recommends treating all persons with chronic hepatitis C infection over the age of 12 with pan-genotypic DAA agents. Okay, so most of those include what we call sofosbuvir, velpatasvir, and sofosbuvir, daclatasvir, and glycoprevir, pibretensevir. So those are the DAA that can be used to manage those patients. The prevention is very important. Primary prevention, we have no effective vaccine against hepatitis, so we need to take necessary precautions to, you know, for especially to prevent the condition among inject drug